Time now to discuss living with cancer with Dr. David Ryan, who's the co-author of a book along with Dr. Vicki Jackson, Living with Cancer, a step-by-step guide to coping medically and emotionally with a serious diagnosis.
So I'm going to bring this up a little bit to about 30,000 feet. You got the experience of what I get every day coming to work at MGH, which is to interact with incredible people, young people often, who are changing the face of cancer and changing the field. It's like, I like to say, it's like watching an episode of Nova every day. I was an English major in college. I wasn't like Matt Fergal, who is a card-carrying scientist. I came into cancer in a different route. I actually wanted to be an orthopedic surgeon and just realized that I couldn't cut straight or see in 3 dimensions. And so here I am doing cancer medicine. And so what I'm going to talk to you today, though, is about 2 concepts that I think everybody in this room deals with, and deals with almost on a daily basis, and probably has infinite numbers of stories to tell about those 2 concepts. The first is prognostic awareness, and the second is how your idea of time changed after you got diagnosed with cancer. So prognostic awareness and time. And this came about, my thinking about this came about because of the book that Vicki and I wrote together. We wanted to write a book, and the 2 big themes were, we wanted to show how at MGH we brought together palliative care and medical oncology together in the same room, and how that changed the way we actually take care of patients and changed our approach. And that approach now is kind of metastasizing, if you will, across the country. And it's really started here at the MGH, and it was started because of an experiment of sorts. Vicki and I were both young oncologists, or she was a young palliative care doctor, I was a young oncologist about 20 years ago, and we were thrust together into clinic, and our respective bosses said, work together. Now, historically, palliative care and medical oncology worked apart, and we were suspicious of each other. And so we were told we had to see patients together and figure out how to make it work. Well, it turns out that we figured out that we needed each other terribly. To give each patient the best chance of the best case scenario, we needed each other to come together and take care of patients together, because when you're an oncologist, you're worried about the T cells and the B cells and the chemotherapy and the neurotoxicity. But when you're a patient, you're worried about, am I going to be cured? Am I going to get really sick? What's going to happen to my husband? What about my kids? And on and on and on. And there's all sorts of other things going on. And that you need a physician who can help manage that, or a nurse practitioner who can help manage that other stuff with you as you're going through it. And it turns out it makes things much better. And so this experiment led ultimately to this book. And so we wanted to share the experience of what it's like taking care of patients together. But we also wanted to write a book that was kind of a kind of what to expect when you're expecting, if you will. You know that book that everybody gets when they're pregnant? We wanted to write that for cancer. And so we went about and did it. And there's 2 areas that we struggled with. One we left out of the book, and that was survivorship. We left that out of the book, but I'm going to come back to that. And the other area that we struggled from the beginning to the end was talking about prognostic awareness. So prognostic awareness simply is, does the patient understand their own prognosis? Do they understand what's going to happen to them? And in the era of immunotherapy, it's becoming harder and harder and harder. If you're in your 9th line of therapy for multiple myeloma, and all of a sudden, you're facing really probably death in the next 3 to 4 months, and then you get a CAR T therapy and you're not, and not only are you not facing death, all of the cancer's gone away. What's my prognostic awareness? How does that play into my life and how I'm thinking about what tomorrow's going to bring? So prognostic awareness and talking about it as an oncologist is probably the hardest thing that we have to do, and in getting people to understand how we understand the disease, getting them to understand it well enough to really make hard decisions about which direction I need to go in. So let me tell you a story about when I was a young, so I was about Matt's biological age anyway. I was a first-year attending, and I saw about the same time 2 women. And these 2 women I followed over the course of the next 5 years. And they literally, I remember I see patients, I used to see patients every day of the week almost, but these two women came in almost on the same day, and they were like a Tuesday patient. And you know what that's like. You pick your day, and it's really hard when you get off of your day. So one patient, they're both women. One was was taking care of a 60-year-old woman. She, mom and a lawyer, and she had 3 kids. They were grown out of the house, and she presented with stage 4 colon cancer. Now, stage 4 colon cancer is usually not curable, but hers was isolated to the liver. And she had about a 10% chance of being cured. So a 90% chance of the cancer coming back and dying over the next 3 to 4 years. And at that time, you know, if it came back after we gave her all the chemotherapy and the surgery, the chance of dying really was pretty rapid over the course of a year or so, was the average, what happened to the average patient. And I remember talking to her about it, and she was quiet, and but you know, we got along okay, and we moved ahead, and she went through her chemo, and she went through radiation, and she went through surgery. And then we started following up every 3 months at first, and then every 6 months. And then by year 5, we had a scan, and everything was clean. I said, "Hey, Maria, I think you're cured." And she burst out in tears. But they weren't tears of happiness. They were tears of anger. And she then proceeded to yell at me. And she yelled at me because she said, "You should never tell anybody that they have only a 10% chance of being cured. You should never tell anyone. You devastated me these last 5 years. You didn't give me enough hope." And I was shocked. I just sat there like, oh, wow. You know, I was still trying to figure out how to be an oncologist and trying to talk about prognosis and prognostic awareness. The next week, right, her counterpart comes in. Her counterpart, let's call her Joni, because we won't violate HIPAA here at Mass General. So Joni actually was younger. She was in her mid-30s. She had just been married when I first met her, and she had a stage 1 colon cancer. And the stage 1 colon cancer has about a 90% cure rate. There's usually nothing we do. It's as good as it gets in cancer medicine, in solid tumor medicine. And so Joni, we started up on follow-up period right away because we didn't need to do any chemo, radiation, any more surgery. She was fine. And I said, "Hey, you're probably cured of this, and we'll just see you and make sure everything's okay." Boom, boom, boom. At the 5-year anniversary, she comes in, liver function tests are elevated, we get a CAT scan, she has widespread metastatic disease. She bursts into tears and starts yelling at me the next week, literally yelling at me. And she said, and the essence was, "You should have warned me. You should have told me that this could come back. You know, 10% is a lot. I would have lived my life differently had I known that I was going to die from this cancer over the next year," which she subsequently did. And here I was, you know, 35. I didn't know what to do. I was trying to figure out how to be an oncologist, how to talk about it. Talking about prognostic awareness is the hardest thing that we do. And so now I've evolved, and Vicki and I struggled throughout the entire book in terms of talking about prognostic awareness. How do you do it, and how do you make sense of it? And I think one of the ways that we've started to talk about it in a better way, and I use a story, and I love the theme for today, which is own your story. So you're going to get to hear my story, which is from the other side of the exam room. I often tell the story when I'm talking about prognosis, whether somebody has a 10% or a 90% chance. I tell the story of Cece Wong. Cece Wong is a famous radiation oncologist. He grew up in China, and he's no longer here. But I remember him because he was this incredible figure when I was a young oncologist in training. And he often had like 10 or 20 people trailing behind him in a room. And he was old-fashioned and traditional. He had grown up in China, and there was very much this hierarchical structure that he had brought with him from Asia over to America. And you never challenged Cece Wong. And there was this famous story at Mass General where He walks into his room, and 10 people come in with students and residents, and this woman says, Dr. Wong, what are my chances of being cured? And she had this terrible neck cancer, throat cancer. And she really only had about a 10% chance of being cured. And he said to her, Mrs. Smith, 50-50. He walks out. And one of the medical students says, chases him and says, Dr. Wong, that woman doesn't have a 50-50 chance, and that would never happen in China. So everyone was like, oh my God, you can't challenge Dr. Wong in the middle of the hallway like that. And so he turns around and he says, for her, it either comes back or it doesn't come back. 50-50. I tell that story now to every single person I talk to about prognostic awareness, because the truth is, when you have cancer, there's a before cancer and an after cancer, and there's a 50-50 chance it's going to come back. And that's the reality. It's a binary thing. Either it's there or it's not there. And when you're in survivorship, or if you have a slow-growing cancer and you don't know when is it going to get resistant to the chemotherapy that's keeping it under control, it either is going to happen or it's not going to happen, and you don't really have much control over that. So that's prognostic awareness, and we all struggle with it. But it leads to the second thing, which is when you start to understand it, how does it impact the way you think about time? And so the funny part about watching, not funny, haha, but funny, odd, the funny part about watching people go through cancer diagnoses, and I've watched at this point probably thousands of people go through it. I've been doing this since 1990, since I came up here in 1996. And I would say this. I would say there's an enormous amount of trauma that occurs to patients. In fact, what we do to people, and what you just saw what Matt does to people, it's violence, right? We inflict violence on people. And sometimes those scars are visible. You have major surgeries, and sometimes they're visible on your face, sometimes they're visible on your limbs, and you walk with a limp, or sometimes you can't see correctly, but they are scars, physical scars. But the harder scars, I think, are the emotional scars. It is, and we are starting to understand this, it is PTSD. It is post-traumatic stress that people go through, and that when they emerge from it, it changes them. There's a before, and then there's an after. And I would say watching people go through this, the number one thing that starts to happen is how they look at time in their lives. And how can they control it? Because I think the hardest thing for cancer patients, or I shouldn't say one of the hardest things for cancer patients, is all of a sudden you're bopping along in your life and things are pretty good, and then bam, you get a diagnosis of cancer. And you're told by somebody who's half your age when to show up, where to show up, you're going to draw blood every 4 minutes, and you've lost complete control of your life. Complete. And how do you get that sense of control back? And there's a kind of nice regimen to getting chemo and radiation. And there's a but, and then all of a sudden you're told, okay, you're done. I'll see you every 3 months. And in fact, no, you're going to see, you're going to alternate with the nurse practitioner. So you're not even going to see the nurse practitioner who you love or the doctor who you really, rely on. You're going to see them every 6 months, or maybe your follow-up, if it's a localized small breast cancer, you're going to see them every 6 months, and so you're not going to see the doctor or the nurse practitioner. You're going to see them once a year. These two people who've been incredibly intimate and a part of your life, all of a sudden, boom, it's like getting kicked out of the nest. And how does that make you feel? And so we talk about survivorship, and we kind of kick people out of the nest into this post-traumatic stress world and to try and figure out how to deal with it. So I would say, looking at it, I'm going to tell you 3 quick stories before I finish and take questions. 3 quick stories about the kinds of patients that I see that in this kind of survivorship period, we'll call it, or surveillance period. So And I'm going to break them down for you into 3 categories. And I'm going to give you the exceptions, and I think all of us can see ourselves in each one of them in each of our lives, but I'm going to give you the exceptional stories to make the point. So the first one I'm going to call the one that makes me worried. The second is the one that makes me sad. And the third is the one that inspires me. And so what I want to leave you with is I want you to be inspired to be you. So let me tell you about the one that I'm worried about. So again, names have changed, circumstances slightly altered, so we're not violating HIPAA. So I'm going to talk to you about Anne. Anne is a 40-year-old woman, 3 kids. She's an accountant, and she got diagnosed with a bad colon cancer. As an oncologist, you always remember the stage. Like, we may not remember your name or your brother's name, like if we bump into you 30 years down the road, but we will remember your stage. It is seared on our brain because everything, and that's terrible, right? Because you're not a number, you're not a stage, you're a person. She was T3N2. So she had a T3N2 colon cancer, which means that she has a 70% chance of the cancer coming back and dying from that cancer over the next 5 years. And after the chemotherapy was done and after she went through it all, and we went into the follow-up period, so I'm worried about her. And why am I worried about her? Because next time she comes in, she looks great. She's lost about 5 pounds, but it's not like a bad 5 pounds. She's gained muscle. And I said, Ann, what are you doing? And she said, I took up running. And I'm also doing 2-a-days. I'm running in the morning, and I'm doing CrossFit in the afternoon. I'm like, oh, that's great. You look great. Things are going well. And there were things that she could control about the cancer coming back. She was eating a Mediterranean diet. She was taking aspirin. She was taking vitamin D. She was exercising. Those are the 3 things that you can do for almost any solid tumor. And that's about it. The data is kind of murky on how much it actually benefits, but that's about all that we think in the field right now that you can do. 3 months later, she comes back. She's now a triathlete. And she's sitting with her husband, and I said, well, how's it going? And now he's into it. And I'm like, okay, that's great. Where are you off to? And they're traveling off to the West Coast to do some triathlon. 3 months later, they come back, and she is like fit as a fiddle. I mean, not an ounce of fat on her. She's doing 2-a-days. She's a triathlete, and then they pull out the list. And the list is, and as an oncologist, we all know what that list is. It's about 20 supplements. And they want me to go through the list of 20 supplements that she's on. And finally, I just said, after we go through it, I'm worried about her. Because what we do know and what the science shows us is that people who are on multiple supplements, who are doing this kind of mega workouts, they are struggling emotionally. They are at risk for a major depressive and anxiety episode. And so I said to her, how are the kids? And tears come pouring out. 2-a-days, working as an accountant, trying to be a mom, trying to be a wife, the whole thing is falling apart. So I'm worried. Let me tell you the one I'm sad about. So Bill was about 60 when I first met Bill. Bill had a gastroesophageal cancer. Bill drank a little too much. Bill ate a little too much. Bill smoked a little still. Cigars. He had cut back on the cigarettes and was smoking cigars. And he was highly successful lawyer. And Bill actually, thankfully, got cured and was in the follow-up period of it. And I would talk to him about it, and every time he came in, it was like nothing ever happened. The cancer didn't happen. This huge trauma that he went through, the surgery he went through, the chemo, the radiation, everything, he still smoked a little too much. There's no such thing as smoking too much, right? He smoked a little. He drank too much. He ate too much. And the other thing that had happened was when I met him, he and his relationship with his wife was really strained. They were great together when he was going through the treatment, but then it was strained again as I was doing the follow-up. He was estranged from his oldest, and that never got repaired. And afterwards, at about the 6 or 9 month follow-up, he was back to working 60, 70 hours a week. He wound up, I got a call one day about 5 years after his diagnosis from the cardiologist. He was in the CCU, And I went up to see him, and there was no family around, no nothing. And he had been working all that time. And so that, I would say, is sad. And his still stayed estranged from his son. He wound up dying of cardiovascular disease. And that was sad. And then let me tell you the last story. So this is one of my favorites. And it's nothing dramatic. Well, it's kind of dramatic, a little bit. So this, I'm going to call, I want to call her by her name, but I don't want. So I'm going to call her, let's make up a name, Mary. Mary's a good name. So Mary had pancreatic cancer, and Mary I met almost 20 years ago, about in 2000, roughly. And Mary had a bad pancreatic cancer. She went through chemotherapy, radiation, surgery, and then about 8 months later, it came back. She had an isolated nodule in her lung. And you know, it's pancreatic cancer. Median survival for when the cancer comes back, if you don't do any chemotherapy at that time, things are getting better now, but at that time, the median survival, and we're talking prognostic awareness, was 3 months. If you did chemotherapy, the median survival was 6 months when it came back at that time. So we went through the whole thing, and I said, you know, why don't we take it out? It's isolated. We do it for other cancers. I'm not sure how much it matters in pancreatic cancer, but you're young and healthy. Let's take it out. We took it out. She's still alive, doing well today. And she just had the right biology. So what happened to Mary, though, was that everybody on the pancreatic cancer internet, you know, all the blogs, all the chat rooms, they all find out who she was. And she got called all the time. And as we were following up, I got to know Mary very well because I was seeing her every 3 months for almost 10 years before we felt comfortable enough to go to every 6 months. And then after about 10 years, I said to Mary, I'm like, how does this affect you? Like knowing, like you're the 1 in 100 who got cured, and you shouldn't be cured, and we're not even sure you're cured. I mean, it could pop up any day now. And she said, you know, after the first year, I said, okay, and she said, I used to pray a lot, and I said, okay, I'm going to do something great with my life. I'm going to write a book. I'm going to travel. I'm going to start a charity. I'm going to do all sorts of incredible things. And she said, none of that happened. And she said, I started to realize in talking to people who they would just keep calling me, you know, how did you do it? And I realized at the end of the day, it was just biology. I had the good biology. I won the lottery, and these other people didn't. And it became really hard to watch people with pancreatic cancer die from their disease. And they would call me. And I said, well, so how did you kind of come to grips with it? And she said, well, I decided I was going to control the things that I could control. So every day I wake up and I rededicate myself to being the best mother I can be, to being the best sister I can be, to being the best neighbor I can be, and to being the best spouse that I can be. And I try and do something kind for somebody in that sphere every single day. And that's the only thing that I've decided that I can control. That, to me, is inspirational. So, make your story, own your story, and be inspirational. If you're in this period, you can do it. Control what you can control. Thank you. Any questions for anything? Yes?
And in your book, which I have, so it talks about the importance of it. So when does palliative, I'm doing it now, but when does palliative care, when do you seek consultation?
So I would say if the world was, if money didn't matter, and there was endless amounts of palliative care in the world that I could take and help me out, I would say everybody should have a palliative care consult at any moment along the way. That's what, and there's a kind of outrageous political statement there. The truth is that there's not unlimited resources in the world, and there's not unlimited palliative care doctors in the world. So what I would say about palliative care is if you feel that you're struggling with any aspect of your care, a palliative care consult is incredibly helpful. It doesn't matter whether you've been cured or not cured. Palliative care isn't just about end-of-life care. Palliative care is about doing as well as you can for as long as you can with whatever you're going through. So palliative care is a specialty, usually in medicine, not always, but palliative care is a specialty where the physicians do a fellowship in intense symptom management. What we have found is that combining palliative care with oncologic care helps us take better care of the entire patient, not just the traditional medical aspects associated with that. So given though that it is a limited resource, we typically will encourage people to seek palliative care if they have an incurable cancer, and if particularly we're having particular hard time dealing with some of the symptoms or issues that the patient is going through. And we'll always, if somebody asks for a palliative care consult, we'll always arrange for that to happen. There's no question that being positive makes for a better life, makes for people to enjoy being around you, makes everything better. There's no question. What Vicki and I do talk about, and we do talk about in the book, is there is something that annoys us as physicians who care for patients, and that is, and we call it the tyranny of positive thinking. Oh, yeah. And what we mean by that, and I'll tell you a story, and this is a story I don't even need a name because it happens every 6 months, like clockwork. The Boston Globe has an article, usually about a young person, usually they're a coach, usually it's about how they beat cancer, and they bring the same positive winning attitude that they do on the playing field to their cancer, and that's the reason why they beat their cancer. And then inevitably, you're an oncologist in clinic and you're trying to get through your morning, and you walk in the room and they're sitting, Tom or Jill, practically in tears with the Globe open saying, how come I'm not beating my cancer? I'm thinking hard enough, trying hard enough, what is it about it? And so there is a sense in our culture that I think being positive is important, it's great, it makes life better, but it doesn't, so far as we know, impact the biology of that cancer. So, one, I'm sorry you're feeling lousy, but you raised two really good points that I think the entire audience needs to hear. One is this concept of PTSD is real. A lot of it is coming out of the MGH Cancer Center because we have this incredible psychiatry department at MGH, and the psychiatry department is embedded within the Cancer Center through psychiatric oncology. They're also embedded in the research group that does all the supportive care. So Jennifer Temmel and Joe Greer. Joe Greer is our program director for psychiatric oncology, and Jennifer Temmel, they formed the research group, the Cancer Outcomes Research Group, that has done all of the palliative care research and is now figuring out that PTSD is real in cancer survivors and how to manage it. And one of the ways that we're studying is this resiliency program that you went through. Hopefully that is something that can alleviate some of the symptoms associated with this burden of PTSD post-diagnosis. The second aspect, which you point out, is the real physical scars that people are left with: fatigue, GI issues, breathing issues, all sorts of issues that people are dealing with. We and others are struggling with how to come up with newer, better therapies to help people who previously never were cured. Like, the wonderful part about that article that Janet put together was the MGH, it was a phase 2 study in pancreatic cancer. We are now curing people who we never thought were curable in the past with pancreatic cancer. It's remarkable. But there's a subset of patients that have a significant symptom burden that's left behind, and we need to do a better job of addressing those symptoms.
So the question, so the issue of PTSD has come up in cancer treatment and palliative care and prognosis, trying to understand what your prognosis is. And one thing I want to ask is, has there been any discussion around having a social worker or someone at that first meeting you have with your surgeon, your oncologist, your radiologist, and so forth? Because, a lot of us think that we can do this, we're fine. We don't think about the emotional aspect. In fact, the word PTSD never entered my mind in the beginning. I have it, but it took me a long time to realize it and recognize it. And I'm still dealing, still trying to grasp that. So as a understanding your prognosis, that's a really big thing for someone who has quote, survived cancer, right? So I just want to know what kind of thought has been given into that.
So a lot of thought. So social work, like palliative care, there's not enough social workers to go around, and there's not endless resources. So we're trying to figure out the structure of social work in the cancer center, and it's a constant work in progress. Mara Bloom and I discuss it at least on a monthly basis about all the efforts that we're trying to do to meet patients as they struggle with prognostic awareness and PTSD. I would say that just to give you an idea of the scope of the problem, so every single day over there in Yawkey, which you can see from right here when you guys stand up, you can look across. In Yawkey, there's about 800 to 1,000 cancer patients who are roaming those halls every single day, talking to surgeons, radiation oncologists, and medical oncologists. And so we have to figure out in the cancer community a better structure so that the people who have the expertise in these kinds of issues, like the social workers and the palliative care physicians, have an opportunity to interact with patients who are really struggling with them. And I think we as a medical community haven't created that structure yet, but we're trying. So the question is, do we have in the book Living with Cancer Financially? We have a little piece on the impact that it makes, but no, we haven't. We didn't address all of the financial pieces. So we're currently talking, they want us to write a whole series of books, and the two areas that came up, both that they want, this is Johns Hopkins University Press, and we haven't figured out whether we're going to do it yet, is survivorship, and then as a piece of that, the impact to the whole patient, including financial issues that come up. It sure is. Yep. So there, as far as I know, there's no, and the reason is that the medical financial climate, it's basically a microclimate in each of the different, let alone cities, let alone states. And so what applies to somebody in Boston may not apply to New York or San Francisco. What we do have, which has been incredibly helpful, that Mara helped set up, is our financial assistance team. And so what we do is we have a consult with people who deal with the medical finances, particularly around insurance that patients have. And so if you need that, we can always hook you up with that.